I actually used to work with VG. Some of you might remember me. Yeah. So I used to be a therapist here through the partnership with LifeWorks. So I used to work in school-based and started out doing all sorts of trauma trainings a few years ago. And I'm thrilled that it's been taken up by the organization and become such a big thing. I'm really proud of you guys. That's awesome. So it's a tough training today, not in that you're going to be tested at the end, but in that a lot of emotional stuff is likely to come up. So that's part of why Mary provided awesome fidgets. And I just want to say, anytime anyone needs to take a break, please do so. Our secondary trauma training is literally about how to make sure that we're not re-traumatized. And ironically, part of the training about trauma is always a little bit re-traumatizing. So if anyone needs to take a break, feel free. No one will look askance at you at all. You'll notice that Dino's filming today just to give an opportunity for more people to take this training online through, what's it called now, SharePoint? Okay. It had a different name at one point, so I'm still relearning. All right, so let's get started. Our topics today include going over a brief introduction to trauma and trauma effects. Can I see by a show of hands who's done another trauma training? Perfect. Then I get to steam through that. I like that. Okay. We're going to go over secondary versus primary trauma, trauma that's kind of inherent to the healthcare environment, secondary trauma from trauma narratives and from trauma reenactments, and then some skills on how to better manage interactions with patients and how to better engage in self-care. So we're going to have some take-home stuff as well, because nothing is better than actually being able to use it right away. And I am not a formal presenter, so ask questions as we go. How do you define trauma? It sounds like we've been trained already. Does anyone have a definition of trauma that they like?
Well, it's like you're affected negatively.
Okay, so it's a negative effect from an experience. Awesome. Anything to add to that? Too early in the morning, I understand. All right, so some of you might be familiar with Bessel van der Kolk. He's like the trauma guy. He wrote The Body Keeps the Score, if any of you are familiar with that book, and just an amazing researcher. And he defines it as traumatization occurs when both internal and external resources are inadequate to cope with an external threat. And the reason that I really like his definition is because it includes the idea of external resources. Oftentimes when we're paying attention to trauma, when we're paying attention to anything in the mental health realm, we only pay attention to internal resources, right? This is how we get a lot of blaming of people when they are struggling, right? And Bessel van der Kolk recognizes that the external resources, if I have those external resources met, oftentimes I don't need a lot of internal resources, right? So when we look at the effects of an experience, for instance, if someone has a traumatic car crash, when we look at the effects of someone who has a great support system, a family, right, has access to medical insurance, health insurance, right, access to mental health care, their outcomes are so far and away better than someone who doesn't have those resources, right? And that has nothing to do with internal grit or stamina or personal resilience or pull yourself up by your bootstrappedness, any of those sorts of things. It has to do with having those external resources as well. SAMHSA defines it in a much wordier way, because that's what they always do, as individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as overwhelming, life-changing, and that has profound effects on the individual's psychological development or well-being, often involving a physiological, social, and or spiritual impact. So the reason I wanted to include this was not just because it takes 4 breaths to get through, but also because it recognizes that it has a physiological, social, and or spiritual impact. Oftentimes we tend to only focus on the emotional, and we don't pay attention to the fact that it can really change a social environment. Trauma can really change a work environment, right? Can really change a physiological setup for an individual, right? We're seeing this a lot of times, and it gets missed a lot of times in medical settings, right? So we will see a list of symptoms and be able to ascribe it to a different physiological cause when we don't know that the trauma exists.
Patients also don't like to be told it's this.
Absolutely. No, 100%. Patients do not enjoy being told that, because what is worse than I had an experience and it changed me physiologically, right? We like this idea of, you're going to give me a pill or a shot, and it's all going to go away, and it's fine, and it wasn't that big of a deal, right? Because part of our trauma response for most of us is minimizing our experience. And the reason that that's our response is because it's not something that's talked about. Socially, we get this idea of we shouldn't be that affected by these things. We get this idea of, well, if you were more resilient, right? It's not that big a deal. Everyone's been in a car crash, right? Without all the specific context of the trauma that you've experienced. So for that reason, when a physician might say to us, well, this might be related to your trauma, a lot of times we're gonna have a big response to that. So we'll also talk about how to do that in a way that might be more palatable. All right, so some of you might be familiar with this, but I wanted to go through the different categories of responses that we might have to trauma. This will be helpful in seeing it in ourselves and in seeing it in patients. So these are the general groupings underneath post-traumatic stress disorder. And to remind all of us, you don't have to have post-traumatic stress disorder in order to have a trauma effect, right? Post-traumatic stress disorder is one specific type of trauma response. It does not mean that you're not experiencing it if you don't meet all the criteria. So intrusion, which is re-experiencing trauma in recurrent or involuntary intrusive ways. So this could be nightmares, right? This is especially common in little kids. We'll hear of really horrible nightmares that happen recurrently. Dissociations means feeling separate from where you are. All of a sudden, you might notice someone going glassy-eyed. You might notice that they're no longer responding to what's going on in front of them. Intense and prolonged distress in response to traumatic reminders. So for some people, if we use the car accident, and the reason I use that is because it's what we often will consider a lowercase t trauma, in that a lot of people have experienced it. It's traumatic for some in some instances and not traumatic for others. So I use the lower t trauma ones so that I don't trigger as many people as possible. So for instance, if we use the car accident, for some people it's driving past that corner, that street corner, every single time will cause intense distress, right? Could cause hyperventilating, could cause an immediate headache, stomachache, vomiting, any sorts of those things, right? And a big emotional response. So it can be a street corner, it can be anytime you get in a car, it can be anytime you see the color red if a red car hit you, right? It can come up in all those sorts of ways. It can even be anytime that you put your hand across as though you're about to buckle your seatbelt. So anytime you touch your shoulder. Odd things like that can trigger us because that's how our bodies keep it. Avoidance. Persistent avoidance of trauma-related thoughts or feelings and external reminders. Avoidance is one of those that becomes really, really important in a healthcare setting especially, because if a patient or if you have had a traumatic experience in a healthcare setting, you're going to want to avoid all healthcare settings. This is one that comes up a lot of times for dental providers, where people will have had, so one of my clients who I've worked with in the past, for instance, had an experience in which they were bound down to the chair because they said the Novocaine wasn't working. And they said, oh, you're just a kid, you're overreacting, bound him to the chair, did an entire procedure that he could feel the whole thing of, right? His response to that, not surprisingly, was being very avoidant of dental care, right? And didn't go to a dentist for the next 20 years, right? Came to me to try to get over it because recognized that there was a lot of things going on in his mouth and that causes other physiological issues, right? So avoidance is a really common response. If you think about it, what sounds more functional than avoiding a place that you've been traumatized, right? That's a pretty great choice. The problem is when it has these long-term effects of not being able to get health care, for instance. Negative alterations in cognitions and mood. So inability to recall parts of trauma, right? This is one that we see in the court system a lot when someone tries to prosecute for trauma. And a lot of times, individuals are unable to remember portions of it. That is a very functional neurological response that we have, right? Our brains say, hey, that's horrible to remember. It's going to be better if you don't have to remember it. Right? That's a very functional response. The problem is it doesn't work well when we get out into the world because then we have this confusion of what happened to me and what am I missing. Negative beliefs and expectations, distorted blame of self or others for trauma, fear, horror, anger, guilt, or shame, diminished interest in activities, alienation from others, constricted affect. If we take just that portion, does anyone have a guess of what people tend to be misdiagnosed with instead of diagnosed with a trauma disorder? Yeah. Depression, anxiety, ADHD, all three of those are high misdiagnoses, right? You can't pay attention, you can't concentrate, you have a negative view of yourself and others, you don't want to go out and do things, you have a depressed mood, right? You're very anxious about things. So a lot of times, trauma gets missed because we say, oh, that fits in another box. I've got a box for that already. ADHD gets even more popular as misdiagnosis because of this piece, which is irritable and aggressive behavior, reckless behavior, hypervigilance, exaggerated startle response, and problems in concentration and sleep disturbance. So when we talk about hypervigilance and exaggerated startle response, that could look like for someone when a door slams, if you see someone jump, right? So I have a past history of trauma and I have an exaggerated startle response for certain noises, right? And so what will happen is all of a sudden I'll just be sitting there, everything will be fine, and I will jump, right? And I know everything's fine, and rationally I know this, and cognitively I know this, right? But you can imagine when that is exaggerated in certain environments, it's going to be a real problem, right? If you see someone jump in the middle of a meeting, you think, that's weird, I wonder if they're okay, right? If you have an exaggerated startle response anytime someone opens a door, right? So for a client I worked with, anytime they heard a door down the hall open, full tears, sobbing, panic attacks type presentation, right? Anytime a door opened down the hallway. Is it easy to maintain work if that's what you're doing? No, right? This person happened to take care of kids for a living. They can't do that every time a door opens, right? It's not going to work to maintain their job. So these are the general groups of signs that we tend to see. If there's one thing that you can remember about trauma, I'd like it to be this. Trauma is adaptive. Trauma responses are absolutely adaptive. We tend to think of them as non-functional, right? But they're all functional in a certain context. So I put a pink chameleon up here, which many people go, huh? The reason I do that is to give this idea. If you grow up in a physically abusive environment, for instance, right? We'll call that environment pink. Maybe what you learn in that pink environment is to have a certain response. So, all right, I'm in a pink environment, I'm going to be pink. The only thing that gets paid any attention to here is when someone hits. All right, when dad hits me, mom pays attention to me and takes care of me. I've learned an important thing. Hitting gets attention. Okay, great. So then I go to school, and my response is, I really want attention from the teacher, so I sock the kid next to me, right? All of a sudden I get attention, but it's the wrong kind of attention. Everyone's yelling at me, and I don't understand why this is a bad thing, right? I've learned it. Pink was the one thing that I needed to be in order to fit in order to get my needs met, right? Then we scroll that out to adulthood, right? And maybe violence becomes yelling, maybe violence remains violence, but you have someone come in at the front desk to check in at the clinic, right? And they're 10 minutes late and they get told, I can't be seen. And they start yelling and they start threatening. Not because they say, this will be fun, but because that's what they were trained to do. That's what they learned to do. That was the functional response. That was how they got their needs met, right? It was an effective coping mechanism. So all of these trauma responses are functional adaptations to trauma that are non-functional when they're applied to different contexts, right? Because all of a sudden, you take that pink chameleon, you put them out in a blue world, and everyone goes, what are you doing? Why are you yelling at the front desk person? They have no power in this situation. They don't get to choose whether you get to go to your appointment or not, right? All of a sudden, a pink chameleon in a blue world starts to look a little bit bonkers, and we tend to judge them because we don't think about the context that they came from. Secondary trauma has a pretty broad definition. You might have heard of it be referred to as compassion fatigue, right? I actually literally heard that on the radio this morning. They were talking about different towns in Mexico having compassion fatigue for caravans of migrants who were coming through, right? I've given so much to people, I can't give anything more, right? I assume that since many of you are in care positions, you've had that feeling before, right? It's also a common feeling for, parents to have. I've given so much. I can't care about this right now. I can't care that you can't find your left shoe, right? I'm out of it. I have no more to give. Countertransference is also a term you might have heard. We use that especially in the psychology field, this idea of when I'm coming into the room, not only am I there to help you, not only am I there to support the person I'm with, but I'm also bringing a lot of my own stuff, right? I'm bringing my own trauma into the room automatically. So if you talk about something that triggers me and my countertransference isn't well managed, it's going to come up, right? So for me, after my mother died, I knew that I couldn't see anyone who fit her demographics, right? I was like, if you come in and you are older 60s, blonde woman, I'm not going to do well. And so for a long time, that was a kind of group that I couldn't see, right? Because I was able to recognize that. Now, you also notice that I had the support from my community and from where I worked to be able to do that, right? Which is a hard and rare thing, especially in healthcare. And then vicarious traumatization is another term that you might have heard of. So vicarious traumatization was a word that became very popular after 9/11, for instance, because we found that a lot of people were having all the symptoms that met criteria for post-traumatic stress disorder or for another trauma disorder just from having watched it on TV. So for those of you who were old enough at the time, you might remember it was played on every TV, on loop, over and over again, endlessly for months, right? That was all we would see, every picture, everything. And so what it became was we started to notice that just through media exposure, people were actually expressing symptoms of trauma. So the sources can be narratives, having heard a story, videos, or secondhand recounting, right? So I heard about a time that this happened. Even that can cause traumatization within us. And the reason for that is part of what trauma is, as we go back to that Bessel van der Kolk definition, is not having the internal and external resources to cope with it. When we learn about traumatic things that have been happening in the world, we automatically feel like our external resources are depleted a little bit, right? The world's not as safe as I thought it was. Oh, what does that mean about the world, that that can happen in my world, right? That can happen around me. And it can also happen from reenactments. And so by reenactments, what I mean is that person coming in and yelling at the front desk because that's how they get their needs met. That's what they've learned, right? It is that sense of when you've had a conversation with a client or a patient maybe, and you are sure what you said, you're absolutely sure what you said, and they have a completely different interpretation of what happened, right? That in and of itself can be really traumatizing because you recognize that, okay, I know what I said, I gave the full AVS, and on the AVS it was written out exactly what I needed you to do to manage your healthcare, and then you're coming back and telling me, you didn't do that, you didn't take care of me.
You didn't tell me any of that.
Right.
You never gave me exercises.
Exactly. You told me none of these things. How possibly could I succeed, right? And so all of a sudden we're feeling attacked and feeling like we're not doing and providing the care that we desperately want to provide, right? And even that is a reenactment that can re-traumatize us. And so the reason I harp on these is because they're small little things that I would imagine most of you have experienced probably already this week, right? Dr. Crawford says yes, absolutely. These are things that we experience every single day, a lot of times, right? When I think of how many times, when I talk to people who work in the call center, how many times they have this experience of a reenactment over the phone, right? And over the phone, I would argue is even harder. We have a lot less information coming to us, right? Often in the call center, we have a lot less power than maybe a provider might have of being able to say yes or no to things, right? And we have these enactments over the phone where we don't have the information of the person standing in front of us. We can't give a smiling, warm, welcoming face. It's all over the phone. We have a lot less ability to be able to do it. We have a lot fewer internal and external resources to be able to deal with those reenactments. Sources vary for secondary trauma, but the symptoms don't vary from single trauma, okay? Trauma that you experience can have the exact same effects as secondary trauma. To add to that, when we have our own existing trauma, which if you are like the average person, you probably do, right? We all have our own experiences of trauma, whether it's little t or big T trauma. We all have our own experiences of not feeling safe in the workplace, not feeling safe walking home. We all have our own experiences of maybe being abused, right? Sexually or physically or emotionally. We all have these experiences. Trauma is very, very common. And what happens is we find that it builds on itself. So if you've had an experience of trauma, whether little t or big T trauma, if you've had that experience, and then we have a reenactment that we get to experience at work, we're more susceptible, right? We're more susceptible to struggling with that. Now I say that as a warning, but I also say that as someone who has experienced a lot of trauma, and trauma is what I specialize in, right? All day long what I do is I work with people on severe trauma, right? So it doesn't mean you can't do it. It just means that we need to be hyper aware of secondary trauma because we are more susceptible. So visible trauma responses that you can see in yourself and in others, right? And these are specifically for others because they're really obvious. When you see someone who is quick to anger, right? What tends to happen, and the reason that I write these out, is what tends to happen is our first response when someone is quick to anger is to go, uh-oh, what did I do? Now that can be a helpful response, but it often makes us defensive as opposed to helping us realize that their anger might be about something else. So if someone has a pattern of being really quick to anger, we might want to consider trauma. If someone is quick to mistrust, right? Quick to have the understanding of, I don't trust this person, I don't feel safe with you, right? That is also a sign. Seems spacey or out of it. This is one of those that we tend to attribute to drugs. Most of us do. When someone checks in and seems spacey or out of it, when you say, what day is your appointment? And they say, oh, I'm not sure. We tend to go drugs first, right? And drugs is a very good differential, right? Very important to rule that out. But oftentimes what's happening is that they are feeling triggered in some way and therefore are responding by being out of it. Struggles to report on own actions and recalls actions of others. So remember that one of the things that our brains do when we experience trauma is to kind of wall it off from ourselves to keep us safe, right? So the tricky part is much like our increased arousal, right, might show up at inappropriate times, our forgetfulness also shows up at inappropriate times, right? Times that you're not necessarily in a stress response. It'll show up. You'll say, okay, well, I don't remember that conversation at all. I'm so sorry, right? So when I think about this, I think about after my mother passed, I had to go and do like financial stuff to close her will out, right? And financial is not my field, just not at all. Like numbers I'm fine about. As soon as it's money, I'm like, I don't know what any of this means. I sat through an entire meeting with her financial person, and at the end I was like, I'm so sorry, Mike, I have no idea what you've said. I have a really nice spiral drawn on my paper, and I have no idea anything what you said, right? And it wasn't just because I hate finances, it was because I was in an emotional place and it completely blacked it out. I heard nothing that he said. Sweet man had to go through the whole thing again, and I was like, I'm so sorry, right? And wrote it all down for me. I was like, here, you can take it home. It's like, thank you so much. Rare in a financial person, I find. I was very lucky. Someone who complains that the system is unfair or feels that they are being personally targeted or blamed, okay? So I imagine you all have run across this. Now, we have this difficult thing of individuals who are more likely to have experienced trauma are also individuals who are minorities, who also have less access to things, right? So we have this tricky dual thing where a lot of people who have experienced trauma tend to say that the system is unfair. Also, sometimes the system has been very unfair for them, right? So we have that double whammy of feeling like it's been so unfair for so much of my life that I'm sure that it is, that I'm looking for that confirmation. And so anything that you might say, right? Like, oh, well, I'm sorry, we're running late today, so you're gonna have to wait an extra 5 minutes. That can elicit a very big response, right? And I don't know many medical centers that aren't running 5 minutes behind most days. Or more. Makes appointments but does not attend them. So when I was with VG did a really nice job of doing follow-ups for missed appointments, as opposed to doing what some clinics do, which is one appointment missed, you're no longer on my panel, or I'm never gonna call you again and follow up with you, right? So at least when I was working at school-based, and I heard good news from other clinics as well, that was one of the policies. And the reason that that's so important is because a missed appointment doesn't mean I don't want care. A missed appointment doesn't mean I don't value your time. A missed appointment often means I couldn't make it in the door, right? And because of that awesome policy that VG had, one day what I got to do is I called immediately, 5 or 10 minutes into the appointment, and they said, yeah, I've been sitting in your parking lot for half an hour. I'm so triggered I can't make it in the door, right? So we got to go and do a session sitting in the car, right? Cool, this is where you can meet me. I can meet you here. I can do a session in the parking lot. That works out just fine, right? So paying attention to the fact that making appointments and missing appointments doesn't always mean it's about you. Does not tell the truth. What a triggering and difficult one for a lot of providers to deal with, right? For a lot of people to deal with. This idea of not being able to tell the truth.
Well, we're also taught in medical school and residency that patients will.
Yep.
You ask them, how much do you drink? Oh, I drink occasionally.
Mm-hmm.
Attending comes in and goes, so how much do you drink? Oh, I drink occasionally. How many drinks do you have, per week? Oh, I drink a 6-pack every night. True story.
Yep. No, absolutely. Absolutely. And there's 2 reasons for that. One, obvious shame, right? And the other one is if you've had an experience of trauma time and time again, you've learned I can't trust the world. So I'm not going to tell Dr. Crawford that I drink a 6-pack a night because I don't know what Dr. Crawford's going to do with that information, right? I can't trust that that will be taken in a helpful way. I can't trust that that will be, right? And it's not even a cognitive decision. And that's the really important thing to remember. It's not a cognitive decision of, I'm going to obfuscate, I'm not going to tell you the truth because that's going to work out so much better for my medical history, right? I think rationally most people know you're going to serve me better if I tell you I drink a 6-pack a night. You're going to know certain things to test me for. You're going to maybe look at my liver and figure out some things and encourage me to not drink so much, right?
6-pack of beer a night is occasional drinking in some families.
That is also true, yes. That is an absolutely true statement for occasional for a lot of people. So it's not a cognitive obfuscation. It's not cognitively choosing to lie. That's the only option that I feel is available. That's the only option that I rationally feel is available to me, is to not trust you. Change his mind about what they want, right? I can't tell you how many times I have, especially when I was working in integrated primary care at VG, where I would walk into a room because the provider just told me, oh, they're really excited to do therapy, they want to meet you. And I walk in, I'm like, oh, it's so great. Oh, you don't want me to be here at all, right? And we have to do the whole process again. Because of course they change their mind about what they want. What do we do when we don't feel safe? we change our mind every 4 seconds, right? If any of you have ever had that weird, eerie experience where you're walking in a parking lot late at night, right? And you're like, I don't feel comfortable. There's something just, I have the willies for some reason, right? Maybe it's rational, maybe it's not, right? And you will find that you make the stupidest decisions at that time because you don't have full faculties, right? So you will maybe like walk up to the door, oh, I should check one more thing to make sure that I'm safe. Oh, I'm gonna run to the door. Oh, I don't have my keys out. What am I doing, right? We are not in our best frame of mind when we're having a trauma response. We're not in a functional frame of mind. That has nothing to do with capability. That has everything to do with neurology. How many of you have seen this triangle before? Okay, awesome. Not as many as I thought. So this triangle is a super helpful thing to have memorized. In fact, if you are someone who works regularly with patients or clients, I would recommend having this drawn at your desk just to remember it. And the reason is because trauma enactments follow these 3 rules. These are the only roles that someone gets to have in a trauma enactment. You can be the victim, right, who's being aggressed upon. You can be the aggressor or the persecutor, or you can be the rescuer, okay? Now, a healthy dynamic means that we can sit in the middle here, right? We can recognize that in any interaction, we are probably being wronged in some way. In any interaction, we are probably being attacked, right? Or we are probably attacking, and in any interaction, we are helping someone. There's always a flavor of that. But in a pure trauma response, what happens is we only get one of these roles, okay? So to give an example of this, one that I used to see a lot when I was working in primary care, I would have someone walk in and they would be, late to an appointment with me. I was working at school-based, it was a bunch of high schoolers. They were often late, right? Because no prefrontal lobe functioning, it's very confusing. So they would walk in, and the first thing that they would do is, they would say, oh, I'm so sorry to the front desk, and it's just my teacher wouldn't let me out, and my car wouldn't start, and it's a long list of ways in which they're a victim, right? And when the front desk maybe wouldn't let them have their appointment if they were egregiously late, right, and weren't following clinic policies or whatever it was, they would go straight into a persecutor role. How dare you? I can't believe that you're doing this, right? Kind of yelling at you, right? Yelling at this front desk person. And so my deal with my front desk people was if one of my clients is yelling at you, just come back and grab me. Like, I'll manage it. It's fine. Because so not their job. They have enough jobs, right? And so then immediately when I would go up and talk to them, they would go into this rescuer role where they would say, Aaliyah, I can't believe you have to work with this person. How annoying is that? The front desk people have all these rules, and I know you don't believe in these rules, and it's so hard, right? And so the tricky part then is we're all pulled into that triangle, right? So the front desk person, as soon as they are hearing this victim role that the person has, they want to go into the rescuer role. As soon as they are hearing the persecutor role, they automatically go into the victim. The tricky part about being in this triangle is you don't have a choice anymore. And this is the primary way that we get pulled into a secondary trauma response, right? Is because when someone is having a reenactment, they pull us into this triangle. So I'm going to give you guys about 5 minutes, and what I'd like you to do is think about a time that this has come up for you. Think about a time in your clinic life or in your personal life that you've had the experience of being pulled into one of these roles, and to kind of describe what happened and kind of map it out. And then added challenge, what's your default role? When you're stressed, what's your default role? Hint, it might be rescuer because you're in a care provider sort of thing. All right, so 5 minutes in little groups if you can, or pairs, to kind of identify. All right, let's wrap up the one we're on right now. Was it easy to come up with an example? Unfortunately. Okay. Yeah, that's perfectly said. Unfortunately easy. Yeah. Did anyone notice what they fall into? Is there one of these that you're pulled more towards? A default response, yeah. Does it tend to be rescuer? Okay. Yeah, rescuer is a popular one, especially for in this field. And victim's a really easy one to fall into a lot of times, right? Yeah. So the reason that I spend a little bit of time on this is because our primary internal resource for this, right, is being able to use our cognition. So when we're aware that this is happening, we can pull back so much easier. The problem is when we're not aware that this is happening, when we're not tracking this, we all of a sudden feel completely out of control, right? I'm not being myself, right? Whenever I get pulled into the persecutor role, I'm like, who am I? Ew, this is so yucky, right? It feels awful to me. And all of a sudden what happens is I'm not only aggressive towards someone else or grouchy, right? But I also feel like not myself, which has this extra layer. So the more that we can be aware of when we're being pulled into this, the better off we're gonna do. The less likely we are to get pulled into one direction, and the less likely we are to get stuck there, right? When we're all of a sudden able to notice, ooh, this doesn't feel like me, right? I wonder what's happening. We're able to pull ourselves out of that reenactment, which automatically, probably obviously, has a much better effect for the person we're interacting with as well. So the primary guidelines for managing interactions when we feel like there might be a reenactment is to assume big reactions from others are not about you and likely are not just about this situation. So to make that assumption first, to say, quick check, okay, is this policy, is this reasonable? Have I had the same conversation 16 times today but have a different reaction right now? Okay, yeah. And then to say, I'm gonna work from the point of the emotion rather than focusing on point-by-point arguments, okay? What tends to happen a lot is when someone is in the persecutor role with us, is we get stuck in that, well, that doesn't make sense, and let me explain why, pedantically, point by point by point, right? Well, this is the policy, and the policy has this reason, because what if, if everyone shows up 20 minutes late, then what would happen? These are not arguments that are going to be very successful with someone who's having a huge emotional reaction, right? It is completely normal if that was your default response, because that's most of our default response. I'll just explain it to you, and it'll be okay. Like, it'll all work out, right? And if someone is not having a big emotional response, that can absolutely work, right? If I'm calm and someone says to me, if everyone's 20 minutes late, then how would the clinic run? I rationally get that. I'm like, yeah, that would not work. This makes sense. But if I'm having a huge emotional response, right, if I've put everything in me to get to this appointment and I am having a big emotional response, you're going to do much better with me if you're able to say, I know this is really hard. I know this is really upsetting. What I would say is, please be very careful about the wording there, right? So oftentimes what happens is we ascribe something. So if Sarah comes in and looks very upset, I might say, it seems like you're really angry about this. How does that feel when I say that to you?
I'm not angry.
Yeah, I'm not angry, but now I am, and screw you, and yeah, you got it slightly wrong. Why did you say that? So we do better when we ascribe global emotions to it, right? I know that this is very upsetting, not I know you're very upset, right? Anytime we put a you word in there, we're not going to do very well. I know this is very upsetting, right? I can't even tell you how many times that I've been able to completely de-escalate a situation just by saying, yeah, this rule's pretty frustrating. This rule's dumb. I can't do anything about it. This rule's really hard, right? Being able to recognize, yeah, the emotion is absolutely valid. Now, does it make any sense that you're having, like, no, because obviously we need to do this, the rule's important. But being able to ascribe a general emotion to it is going to get you a lot farther than going point by point argument, even though I'm sure your arguments are very good and reasonable. Asking for team support. I love the idea of having code words within teams, okay? So when you're working in a team environment, which I think most clinics have, being able to say, right? I mean, hospitals do it for a reason, right? Being able to have a specific code word, right? Something that's reasonable and not like papaya, because you're probably not going to rock that out in the middle of a clinic. But being able to say, hey, I need to tap out, right? When you recognize that you are falling into this trap and if you feel stuck in it, being able to say, right, this was our front desk rule at my clinic when I was working at VG, being able to have a specific word, and I can't even remember what theirs was, but it was something very specific and it meant, I'm now done, right? Someone else needs to step in, right? This is especially important in roles that don't have a lot of inherent power. Because as a provider, we're usually able to say, pardon me, I need to go get a file, or I need to go fill in the blank, right? Whatever it is. When you have the power like that, you're able to leave the room and make up some excuse for it, right? I've even heard providers be like, I have to go to the bathroom all of a sudden. I'm like, well, that one wasn't particularly good, but you got out of the room to get out of the triangle so you can go back in a better way, right? All of a sudden, I have explosive diarrhea, pardon me, or whatever it might be, right? The idea is to disengage, because once you get stuck in this, once you get trapped, it can be really, really hard to get out. So I highly encourage you to have a code word with someone who has, the same position as you, or if you have a supervisor who's actually around, which is rarity, to be able to have a code word with them, right? But to be able to say, hey, I need to go grab one of the purple files. And then, would you mind helping them? Oh, yep. Because what happens when you have a new person step into the situation is they're not already in the triangle, right? So they will have witnessed what's going on and be able to stay more detached automatically. And then plans for support when conflict arises. So the rule when I was working in school-based that we had is anytime someone was having a particularly hard interaction, one of us would check in later in the day, right? When we knew, it was an automatic, like, I know that Yadira was our front desk person. She would come by and just say, I don't even remember what her code word was because it's been a few years, but she would automatically like lean in the door and just say one word and walk away. She was in the middle of her day. She was an MA and front desk. But the rule was she just comes in, says one thing, and that means I know, I'm going to check in with her later today, right? And so she automatically knew that she had support. Just by coming by, she knew that at some point during that day, I was going to come in and check in with her. And usually it was a 5-second check-in. Hey, how you doing? You need a hug? Right? Usually it was really, really quick. But knowing that someone else was there makes all the difference. It's not usually about the support you give. It's about knowing that the support's there. Recognizing secondary trauma responses within ourselves in the moment. So these are things you're not going to notice in someone else necessarily, but things to keep in mind for yourself. Elevated heart rate. Okay? I can't tell you how many times I will have an elevated heart rate and be like, must be in bad shape all of a sudden, acutely in this moment. No, that's not what's happening, right? I'm feeling triggered and I need to pay attention to that. Fatigue, right? I've had my black tea in the morning that I always do, and all of a sudden I'm exhausted today. Maybe I just didn't sleep well for the past 4 days, or maybe something else is going on. Increased frustration and irritability, right? We often put all of those to, I just woke up on the wrong side of the bed today. Maybe that's the case. Maybe you had really bad nightmares, or maybe something is specifically triggering you in the instance today. Heightened feelings of anxiety and stress, feelings of anger, confusions, and feelings of futility. Okay? How many of you at some point during a work day have had the feeling, it doesn't matter what I do, I can't make a difference? Yeah. I've tried everything. Screw it. Right? Especially with those specific individuals who you work with, you've tried, you're like, I have all of my skills. I've used every one of them, right? And so it's important to pay attention to when that's about the interaction with that specific patient and when that's the interaction with you and everyone else, right? So these are all signs to pay attention to. And if you're seeing them a lot, that means we really need to increase self-care. How many of you identify with at least having one of these on here in the last month at work? Last 5 minutes, great. Yep, okay. Okay, and that's a really important diagnostic, right? Because that tells us that we need to make sure that this next portion where I tell you how to work on it, don't worry, we're going to give you skills before we leave today. I promise. That would be awful if I just said, now you have it, you're screwed, you have secondary trauma. Session done.
Okay. So many trainings do that.
I know.
This is what it is. Okay, here's your certificate.
Yep. I'm not going to do that, I promise. All right, effects of secondary trauma on the individual. Emotional and physical exhaustion. Symptoms might look like depression or PTSD and are often diagnosed that way and treated that way. Shift or decrease in sense of hope and optimism about the future and their work. Difficulty concentrating. Intrusive imagery. Okay, and intrusive imagery can be, so for some people it's seeing a face of a patient when they're walking around the grocery store and automatically seeing a face of a patient, right? Or a face of someone they've lost. Intrusive imagery can be if you've had an experience in your life where you felt incredibly hopeless, having that image come up. So for a lot of people who've experienced childhood trauma, having maybe a vision of their dad or their mom's voice pop into their head, right? Or pop into an image in the patient room, all of a sudden that's there. Loss of hope, exhaustion, irritability, and being more cynical. Do we recognize any of these?
By default.
Yeah? Okay.
Cynical, irritable, and exhausted.
Mm-hmm. And I would argue it's probably not your default. It's probably your default in this environment with the interactions that you're having right now. And our goal is to make it not your default. And then increases in errors as well. All right. Effects on the organization. See, and now I wish the boss lady were here for this part.
Can we hold off for
Probably should not call her the boss lady, but in my mind, All right, high absenteeism, constant changes in coworkers' relationships, right? So this can look like on a team having different alliances that form and break up, right? Think about if any of you happen to enjoy middle school and being a girl in middle school specifically, right? It's that sort of changing in coworkers' relationships, right? So, this person is my bestie, they totally get me. 2 weeks, not talking to them anymore. Now this person is my I can only trust this provider. This is my favorite provider. This is my favorite MA. I don't want anyone else to ruin my patients, those sorts of things. Inability for teams to work well together. Desire among staff members to break company rules. Because what does it matter anyway when I don't have any hope and don't have any feelings of power, right? It doesn't matter that I'm taking home this stapler or this toilet paper, or I don't care that I took a 40-minute break instead of a 20-minute break, or whatever it might be. Not that any of you are actually taking breaks, I know the truth. Outbreaks of aggressive behaviors among staff. That's a higher level one. Inability of staff to complete assignments and tasks. Inability of staff to respect and meet deadlines. Lack of flexibility among staff members, right? That's not in my job description. Who's heard that before? Yeah, that's not in my job description. I don't have to do that, right? I can't be flexible to meet these needs because all of my resources are already taken up. They're already used. I can't do anything that is beyond my work right now. Negativism towards management. Strong reluctance towards change. Inability of staff to believe that improvement is possible. Have any of you seen this in your teams? Yeah, just a few of these? Okay. And lack of vision for the future. Trauma is inherent to working in Western medicine because it is an automatically hierarchical and compartmentalized environment, right? Providers have their job at this level. Nurses have their job at this level. MAs have their job at this level, right? It's a very hierarchical, weird thing. I can't tell you how ingrained it is. So when I was working in school-based, it took, so the provider I was working with was Daniel Martino. I don't know if any of you remember him. Okay, Danny's awesome. So Danny and I spent so much time trying to get our MAs to not refer to us in very formal ways. They would always, Dr. Zelder, all the time to me, which is just not something that is important to me. And doesn't work in psychology. It's not a thing that we really do in therapy, right? Because our goal is as equal as possible. And it took probably 3 months of trying to convince them that this was an okay thing to do, because that's how ingrained the hierarchy is, right? The hierarchy is super duper important. The hierarchy serves an awesome purpose, which is to say, I have a lot of information and I can help you. And to have that in a title can be really beneficial. The problem is when it comes up specifically in our working teams, that I know a lot of MAs who don't feel comfortable saying, hey, I don't feel safe with this patient, right? Who don't feel comfortable saying that to a provider of like, I don't want to room them without another person present, right? And to not have that sort of agency for yourself in your workplace is a really vulnerable position. Lack of power, control, agency, voice for the individual comes up a lot. And so just a reminder that traumatization occurs when both internal and external resources are inadequate to cope with external threat. When I don't have a voice, that's not an internal resource, right? That's an external one. When I don't have the chance to talk to someone else, when I don't have the chance to say to my supervisor and trust that they're going to hear me in a supportive way, that means I don't have that external support. If we cannot affect our external resources, we must focus on our internal resource development. So, Mary's in charge of handling the external resources, making everyone trauma-informed, working at the higher levels, which is amazing. I know that all of us don't have an immediate plug into that. So we're going to work on ourselves. Teamwork opposed to isolation. So isolation is the #1 danger for burnout. I'm going to say that again. Isolation is the #1 danger for burnout. Okay? Oftentimes we feel wildly isolated in our jobs, especially because most of Western medical care is one person in a room, that person leaves. Next person in a room, that person leaves, right? So we're only having one-on-one interactions a lot of times with our patients. So we have a lot of automatic isolation. Balanced caseloads is a very important workplace support that can really help with secondary trauma. And when I say balanced caseloads, what I mean is if you are someone who only sees stage 4 cancer patients, that is not a balanced caseload, okay? That is often how Western medical care is set up because it's your specialty, right? So for me, I have a horribly balanced caseload. I see probably 80% of people with complex trauma, right? That's a terribly balanced caseload, right? The way that I manage it is I don't see any clients on most Fridays, okay? Because that is the only way that I can see 7 clients a day with complex trauma and still stand and be at all functional in the room. Accessible supervision and support. So by accessible, I mean if not in the building, having set times that you know you're going to be able to talk to your supervisor, right? I had a supervisor who I could text and know that I would get a phone call within an hour. It was the healthiest I've ever been at work, right? Now I work for myself, so I can always text myself. That's good. Having a safe physical space. This seems like a duh, but one of the things that we tend to do in clinics is we overclutter our exam rooms and our hallways with all sorts of informational posters and little things that you can grab really easily. And what tends to happen is all of a sudden, in order to move through a room, I'm doing this weird little dance, and I don't actually feel safe in my room anymore. I don't feel safe in my workspace because I don't feel like I have the ability to move. I don't feel like I have the ability to easily get to an exit. I don't feel like I have the ability to get away from someone if they're being violent, right? This is one of those insidious ones that we don't notice we feel a lot of times. But what I would do is ask yourselves to go to your clinic, right? Go to your workspace, wherever it might be, and say, do I feel clustered in here? Do I feel like I can get out, right? Do I feel like I have an easy exit route, right? This is something we also forget for patients a lot too. Can't tell you how many times I've gone to a clinic and I had no idea how to get to the exit, right? The MA would be done with me saying, all right, well, you have your appointment all scheduled, thank you. I'd be like, I don't know how to get out, right? It's a maze. There's no signs. Access to an employee assistance program. Group support options. So a lot of teams will have sort of group, what are often called bitch sessions, which honestly is great, right? Once a month we're gonna go out and just vent. Once a month we're gonna go out and do yoga or have a beer or whatever it might be. Employee downtime spaces at work. I know VG's working on that, having little rooms to go to. And support of mental health days, vacation days, sick time. And when I say support of it, what I mean is when you go to your supervisor, does your supervisor groan at you when you say you're going to take time off? A lot of supervisors do, which is really unfortunate. We're like, oh, you know, and there's some nice version of it of we just can't live without you, which feels good, but also does not feel good. Like I need you to be able to live without me, right? I need to be able to go and sleep for 4 days straight. Right? I'm not talking about a happy vacation. Maybe it's just sleeping, right? So to have that support there. So one of the things that I'm going to pass out to you, and I don't want us to take time to fill it out during this because I want to make sure we have time to do things, is the Professional Quality of Life Scale. And what it does, and I gave you the version that is self-grading. Would you like one? Cool. And what it does is it gives you an ability to go through and get kind of a sense, numbers-wise, of where you are in feeling supported and safe at work, okay? And it gives you an opportunity to grade it as well. So I wanted you to have that to take home. One of the things that I would encourage you for follow-up with that is if you're noticing a specific gap and you have a supervisor you trust, or you have an HR person you trust, say, hey, I took this thing and I am really lacking in support in these ways. This is something that I really need you to support me with, okay? Team care. Remember, if we replace the I with we, illness becomes wellness, right? And it's corny, but it's also totally true. Isolation is the #1 cause of burnout, right? Remember that. So one of the things that we would do at school-based, because, I don't know, they let me do it, which was great, was we would do these weekly team meetings. And the goal was empowerment. It was not productivity and it was not production. And the reason that I make that in an exclamatory way is because it's really easy for when we're all in one room to be like, oh, that's great, I really needed to talk to you about this patient. Oh, that's great, I really needed to talk to you about this workflow that wasn't working. As soon as you do that, the team meeting has nothing to do with empowerment, it's all about productivity. So the goal is, and this is something that is from a sanctuary model of trauma-informed care spaces. And so you'll notice the #1 thing is consistency. Consistency is how we feel safe, right? We think about that a lot when we're talking about kids, when we're talking about parenting, when we're talking about teaching. Consistency. So for instance, because I'm a trauma-informed care provider, I greet my clients the same way every single day in the waiting room. They know exactly what I will say to them, they know exactly what's going to happen next, and they know the first question that they're going to be asked, right? So they always know all the first parts, which means that they have this sense of consistency and safety, okay? When we're doing weekly team meetings, it's the same time every week. It's a non-hierarchical model, which means the leadership rotates, not including the boss, because the boss has a lot of leadership time already. So what that would look like is 1 week I would rotate, or I would lead, and the next week Denise would lead, and then Diana, and we'd go around. Okay? And what it looks like is it's the same structure every day. Mary, can I use you as an example?
Sure.
Okay. So I would ask you, if I were leading, I would say, how are you feeling today?
I'm hanging in there.
Hanging in there. Okay. So it sounds like it's a little bit tough right now. Okay. What have you been struggling with?
Juggling many things at once.
Okay. So kind of feeling overwhelmed. Okay. Do you have any goals for this week?
To make it all the way through my inbox.
Okay. Is there anyone here who can help you achieve those goals, and how?
I'd like to think about that.
Okay. Yeah.
Maybe I'll lean on Carla later and
Okay.
ask her for some help kind of plotting it out in my journal.
Awesome. Okay. I love it. And I got a thumbs up there. I got you. I love that. Okay. So it's so telling, Mary's response to that, right? Who can help me with that? I didn't even think of that. We are not trained to think about who can support me with this because this is all on my shoulders. I have a to-do list that is 4 miles long. I will never get my to-do list done. Someone help me? Ha! What? Right? And this is from someone who was very traumatized.
Their own.
They all have their own.
And
Absolutely.
you don't want to be, especially in medicine, you don't want to be a burden.
Yes. And the tricky part is when we are all trying to not be a burden, we all end up burdening ourselves. Right? Whereas just even being able to ask Carla, hey, like, I just want you to know that this is happening for me. Right? Maybe no one can help me, but I want you to know where I'm at. Right? So that if you see me in the lunchroom and all of a sudden I walk by you and don't make eye contact, you know why. You know what's going on. Right? You're able to support me. I'm not alone in this just by your knowledge of what's going on. So this structure can be hugely helpful. It's very evidence-based and shows that we feel more supported when we're able to do this. And again, you will notice if you try it that the hierarchy will automatically pop up and people will start off being like, oh, I'm fine. I don't have anything to do. No, I'm fine, right? And to really encourage those sorts of emotional awarenesses and to say like, hey, I'm feeling overwhelmed. So now I know that Mary's feeling overwhelmed. Am I less likely to send her like 6 emails when I could send her 1 now? Yeah, I am. That's a good thing for me to be aware of, right? Because I can be a prolific emailer, so now I know. Okay. This will seem canned. I'm going to say that right off the bat. And I want us to practice it because it's very easy to do and very difficult to do. So what I want us to do is practice peer support. So think about an experience. It doesn't have to be a big whammy of an experience. It can just be like, you know, I ran out of gas this week and it was really stressful, okay? Or it can go all the way to a more severe experience. And what I'd like you to do is kind of follow this template. Because oftentimes what happens is we feel like we don't know how to actually emotionally support someone when they do talk to us, okay? So this is a boilerplate one. This is easy. If you want to give this to patients who are supporting each other, it's really easy to give. And the idea is the speaker shares about their experience. Listener identifies the emotion shared. So some version of, and you don't have to follow it word for word, unless you are a rule follower, in which case that's fine. Thank you for sharing that with me. It sounds like you felt sad, overwhelmed, upset, frustrated. Did I hear you correctly? The did I hear you correctly is so key here, right? Because oftentimes we get our version of it, right? I can't tell you how many times I will hear a story and be like, I would be so pissed. And the person is like, I was so embarrassed. Oh, a totally different experience than I did, right? So to be able to say, did I hear you correctly? And then the speaker gets to say, yes or not quite. And if not quite, clarify the emotional experience. I'm so sorry to hear that happen to you. That sounds really difficult. What can I do to support you? Do you feel like you want to just be heard and to share, or are you looking for solutions? I would imagine that a lot of you have had the experience before where you have shared an emotional experience with someone and they immediately said, well, have you tried? Da, 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 da. And you were like, nah. All I want from you is, oh my gosh, that sucks. Right? That's all I needed from you. Stop trying to solve it. Right? Saw a few people laugh, so that's clearly a shared experience. So the idea is when we're a listener to be able to ask, which one do you want? I can give both. I can brainstorm with you, or I can just say, oh, that sucks. I can, give you a hug, whatever you might need. Share what support you need, and then provide the support requested as able, and remind about self-care. So problem solver, listen, empathize, and then say, it seems like that experience really shook you up. Did you get a chance to take a break or take care of yourself since, right? And oftentimes the response to that is going to be like, no, I don't have time, screw you, right?
Yeah,
And so,
I have a whole list of patients to see.
Exactly.
I'm told I need to be productive.
Yep.
I don't have time for a break, let alone to go pee.
Yep. And so then what it might be is, all right, what we might have time for is I can give you a hug. I can go get you a glass of water. Do you want to take a deep breath with me right now before you go and do your next thing? Right? Even that can be a joined experience of support, right? Because we will always feel like we don't have time. And taking a deep breath, 3 seconds, and will make a difference. As stupid and minute as it is, it makes a difference. There's science for that, so we can say for sure. So I would like you guys to practice this, as silly as it is. So, and then switch roles when you're done, and then let me know. It should take about 5-7 minutes around there. Give it a go. All right, let's come back together. What did it feel like to do that? What did it feel like?
It was nice. You feel less alone.
Okay, you felt heard. Yeah, okay. It's a really simple thing, but not something we tend to do enough, right? Yeah. Something really cool happened for me when I was getting to watch your faces, because it's quiet here so I can't hear anyone. But all of a sudden, you all started looking a little less stressed. There was like a mask that went down and some calmness came about the room, which was really special to get to see. And tells me that it was something you all needed a little bit of. Yeah, so thanks for taking time to do that. I know it's a bit of a risk to take with people. So we're gonna go over some protective factors for the individual. And this is a bit more of a little diagnostic for you of what's working for you and what's not. So as I go through each section, I would encourage you to kind of rate yourself for where you're at right now. Is this a weak point for you? Is it a moderate point? Is it a strong point for you? These are protective things that will help protect you from secondary trauma and burnout. So social support. Ability to talk about problems and people to talk with who respond supportively and can help emotionally and practically. Okay, so rate yourself along there. You'll have it on your little sheets. Coping skills. Ability to manage uncomfortable emotions in a healthy way Awareness of emotions and how they influence behavior. So when I say uncomfortable emotions in a healthy way, I don't mean I'm really good at suppressing. Okay? I don't mean I'm really good at being like, I am so enraged. It's not here anymore. It's fine. It's fine. Right? Because what happens is, and there's a lot of physiological responses that happen as well that are really negative long term, but what happens is emotionally that doesn't go away. It just stays with you and comes out in weird ways, right? Anytime if you take your Play-Doh right now and you try to squish it really hard in your hands, right? It will come out in between your fingers. You squish it hard enough, it'll come out, not in the ways you want it to. Physical health. Adequate exercise and balanced and healthy diet. Or health diet, because I apparently forgot a Y on there. A balanced and healthy diet. Rate yourself on those. A sense of purpose. Meaningful involvement at work, education, or other roles. Okay? So sense of purpose doesn't always have to be at work. It can be your role in your community. It can be your role in your family, your role with your friends. Understanding of personal values and living in accordance with those values. So a sense of this is what matters to me. A lot of times what happens in our careers is we go towards a career that we feel a lot of value towards. And then when we get in that career, we're going every day, and each day that you go, you kind of forget why you're there, right? Oh, I have to go to work. Not, oh, right, I'm going to work to help patients because that's why I got into this, right? When we reconnect with our values, when we have our sense of purpose and reconnect with that, our day is a lot easier. Because rationally, we know that helping patients is hard, right? We know that that's difficult. When we can reconnect to why we're doing it, we have a lot more energy to do it. Self-esteem. Belief that one's self has value, acceptance of personal flaws, weaknesses, mistakes, and belief in an ability to overcome challenges, right? I can handle this. And healthy thinking. Not ruminating on mistakes, personal flaws, or problems, and ability to recognize personal strengths and weaknesses rationally, right? I know certain things that I suck at, just intrinsically. Like, not good at navigating. Put me on a gridded street, it's absolute hell for me. Put me out in the middle of the woods, I can navigate. Don't know why, it makes no sense. Kind of bonkers, right? But I know that is not going to be a thing. Now, I used to have very negative feelings towards that and be like, oh, what is wrong with me? Why can't I figure this out? Why do I get stressed on gridded street? I was living in New York City. It was very non-functional there. It was very much a problem. And then I found it's like, you know what? I'm good at many things. I am not good at this. I should make sure I get a GPS, because that was, before cell phones had them automatically. It's like, I'm just going to buy a GPS. It is worth it to me to be able to do it, right? To be able to accept that. And a whole bunch of stress went away with that. So rate yourself on these as well. Now, risk factors in the individual. Other directedness. Paying attention to others more than yourself. Okay? Now, a lot of providers have this. A lot of parents have this as well, because we tend to get stuck in that mode of other directedness, right? My job is to take care of all of you. We forget about the oxygen mask rule, right? If I put my oxygen mask on before my child's, that means that I'm still conscious to put it on my child. If they have an oxygen mask and I am unconscious, I am not much help to them anymore, right? And that is true in our jobs too. If I don't take care of myself in order to be around, I'm not going to be able to keep helping people. I might be able to help this one last patient here, but not any patients for the next 4 years, right? Not the hundreds of patients I can help in the future. Lack of strong personal boundaries is a risk factor. Past primary or secondary trauma experiences. Overdeveloped sense of responsibility. Okay? Oh, my patient is not eating healthily. That is clearly because I did not explain it well enough, right? That's probably not that. Impulse to rescue. Lack of support system. Lack of self-care activities. Lack of structure. Okay. So, to that end, self-care. 2 things that you can do every single day, even if you don't have time, I swear. Do a 5-sense check-in. So we're going to do that right now. I'm going to challenge you all. So let's close our eyes if you feel comfortable, and otherwise just find a fixed point on the desk. And I want you to focus first on what you're hearing. If you can find multiple different sounds, choose one and make that sound as loud as you can. Just focus on that sound. See if you can switch to a different sound. Now focus on what you're smelling. It's a pretty clean room, so we're not smelling much, but focus on smell. Focus on what you're feeling in your body. Maybe it's the feeling of the fabric on your skin. Maybe it's cold, hot. Maybe your muscles are tense. If you've been drinking or eating during this, maybe you have a taste. You can focus on a taste. And then open your eyes and just focus on what you see. Not judging, not categorizing, not naming. Just what do you see in front of you? What happened in your body when we were doing that? Yeah. It really brings you down really quickly, huh? Yeah. What happens a lot of times is we get stuck in what we're doing to the extent that we don't notice that we're doing it, right? When we can take a breakdown and do through our 5 senses, we end up relaxing and being more aware of what's going on. This check-in will also be hugely helpful when you're trying to figure out if you're having a trauma response, right? If I check in and figure out what I'm feeling and all of a sudden I'm listening and the only thing I can hear is my heartbeat, that tells me something pretty important, right? The only thing I can feel all of a sudden is the tenseness in my shoulders, right? We can go through an entire day without noticing that we're in pain, like physical pain. We can go through an entire day, and then as soon as we sit down for a second, ow, my neck is so tight. My back is in so much pain. How long have I been like this, right? I've been tensing the entire day without noticing. Another really useful one to do is a body scan. And what that is just clearly checking in. Usually closing our eyes works the best for that. And we just go from our feet all the way up. Are my feet tense? Sometimes we can tense them and then release them will be helpful. It's a progressive relaxation. My calves, I'm just going to focus on my calves. Oh, okay. Just on my thighs, right? And go each part through the body. And by bringing awareness to it, we're able to relax it. So I've given you the professional quality of life scale to figure out what self-care things you need more at work. The general rules of self-care plans, and you'll see that I passed those out. Rituals, consistency, and options. Okay? Those are going to seem a little contradictory. And what I mean by that is, we do best when we have a ritual every single day, right? So when I was working here, someone told me that one of their rituals was as soon as they get in the car, they take their VG badge off and they put it in their glove compartment and they close it. And even the ritual of doing that gives them a sense of saying goodbye, right? All right, I'm done with my work day. I get to be a Leah person now, not a Leah provider, right? For a lot of people, it's as soon as you walk in the door, you take off whatever your work clothes are, right? And you put on something comfy. For me, it's I come home and I immediately have a giant glass of water because that's my transition activity because it feels great because I talk all day. Options are important because oftentimes we will set goals for ourselves without contingency plans, right? So for instance, one of my clients has set a goal that she's going to go for a walk every day at lunch. That's great, but we live in Oregon. So sometimes she tries to go for a walk and it's like, oh, it's just torrentially downpouring. This is awful. See, there you go. And some people are willing to walk.
That is how important the walk at lunch is.
I completely agree with that. For this person, they absolutely hate being wet. So we had to come up with a contingency option, right? So by options, I mean consistently every single time you're going to do a thing. Now, could it be I'm going to go stretch in my office if I can't go for a walk? Sure, and that's great, but to give yourself the option. So a good self-care plan, a very solid self-care plan, includes these options. And I'm going to give you a few minutes, and I would like you to come up with at least one to share with someone before we leave today. At least one option on your self-care plan. You will see that I gave you examples that are written in. So fill out at least one option, and I'm going to have you share it with someone, not with me, not publicly, but with someone here who you can maybe follow up with. And once you've gotten one or two down, I encourage you to share one of them with one of your table mates, and extra credit if you follow up in a week or so to see if someone's done one. All right, so I'm going to ask for your attention one more time just so we can go over the take-home points before I let you all go back to your busy days. We're all susceptible to secondary trauma, but with awareness and interventions, we can prevent the most negative effects of secondary trauma. We cannot prevent our own secondary trauma on our own. Teams and support are necessary for us to do our best work. And it sounds like you've all chosen one self-care activity to try this week. And if you can, please follow up with each other to support this, because we know that accountability is one of the best ways to get these things done, right? Because otherwise taking time for ourselves feels selfish. So I provided a few resources and references for you if you want more information. This is a pretty neat article from The Atlantic from a while ago. I'm also very open to any of you emailing me with questions or contacting me in any way. I don't have it on here, but I'll provide it to Mary, and then hopefully she can pass it on. Does that work? Awesome. And I know we're at time, but I'm around if any of you want to ask any last-minute questions before you run back. All right. Well, thank you so much for joining me this morning. I really appreciate it.
Thank you.